It is 1:30 on March 19th, 2025. Now call the meeting to order with the Franklin Health Department. The first order of business is executive session for 15 minutes. Chris Richards, Chris Curley, and Eric Janae.
You guys.
So we've come out of executive session. The time is 1:45. We were going to extend the executive session under the same RTW code for another 10 minutes. The time is 1:46. Come out of executive session with no decisions being made. And we will move on to agenda item number 3, approval of February 19th, 2025 regular Board of Health meeting minutes.
Sure, I'll make a motion to approve the February 19th, 2025 regular Board of Health meeting minutes.
I'll second.
We have a motion and a second. Any discussion? Hearing none, all in favor signify by saying aye.
Aye.
Aye, motion passes. Moving on to public comment. Do we have any questions or concerns ahead of time that were sent in? If so, please come forward, state your name, and you have 3 minutes.
Freddie Williams. Don't panic this time. I'm just up here to promote the blood drive that we are hosting April 3rd here at the Health District, passing out some info on how to register, some common questions about donating blood, how to register ahead of time. Want to save a few minutes, and more info on why it's important.
Thank you.
This is going to be the 3rd or 4th blood drive we've had here. So our very first one filled up almost immediately. That was about a year ago, and very successful. Red Cross said that we were one of the fastest filling first time drives that they've seen in a long time. And right now for the drive in a couple weeks, I have 5 people signed up. So I would love if all of you would help us out and fill some slots, donate some blood. It's extremely needed right now, as it always is. And you get a $15 gift card sent to you in the email. And there's some giveaway that you can be entered to also. Yeah.
We'll announce it on our next commissioner meeting.
Okay.
But also you might reach out to the city council councils as well. Because I know even like the one in Richland, the city council in Richland, they actually, it's live and it's repeated like 3 or 4 times a day. And people do watch that. And if you have the mayor or the city manager or one of the city council members announce it, it'll be seen over and over by several people. You might get some more people that way. It's just a free way to get it out there.
That's a good idea. We start by opening it just to staff.
Okay.
And so until the 24th, it's open just to staff, but on the 24th, it opens to the public.
Perfect.
And as it looks right now, we're gonna kind of have to rely on just public filling it, unless we get more people to sign up. But I can be extremely persistent and convince people to do it. So I would love to see you all there. And yeah, as we do more in the future, I think our next one is in August. We're just doing them twice a year. So would love to see you. Thanks.
All right, thank you. Anyone else in the room for public comment? Do we have anybody online?
If you would like to make a comment online, you can either raise your hand in the Zoom app or you can press *9 if you're on a phone. Any indicators?
Hearing and seeing none, we'll move on to agenda item number 5, senior staff comment. Okay.
I do have one. Do you want me to go up to the podium? Okay. Sorry, I know you're hoping for a fast. I'll be quick. Okay, I wanted to, so I'm Erin Hockaday, Senior Manager for SNI. I wanted really quickly to update you and maybe have a little bit of discussion about a House bill that's going on right now, going through the committee right now. Where there's been a little bit of concern, cause for concern in the environmental health world. It has to, kind of has to do with local control and some of the work that we do. So House Bill 1154 right now is regarding solid waste handling facilities, and it is kind of proposing to change how solid waste handling facilities are regulated, which would increase the Department of Ecology's oversight in things like permit reviews, enforcement, and compliance monitoring. So currently we operate our solid waste program under a grant that is funded by the Department of Ecology. So they are our technical partners and have some part in review, but we have enforcement authority over those programs. So with this bill, it would expand Ecology's authority and it would allow them to suspend permits. It would require that we send permits to them for review before they're approved. It would also allow them to intervene in our work if they felt like we were not enforcing regulations appropriately. And there's a lot of gray area right now around what that means, which is why there's cause for concern in terms of local overreach. So the bill has already passed through the House. It had a hearing in the Senate yesterday in the Energy and Technology Committee. I reached out this morning. It sounds like that hearing went okay, so it's likely to move out of that committee as well. Wasalfo and Wasac both have elevated concerns about the dual authority, and they're saying that there still might be an appetite for modifying the bill, but possibly not. So if it does go forward as is, I just wanted to bring some information to the board about considering proactively strengthening that program, staffing up that program. Right now, we operate that program with one staff member. Very, very highly technical program, and we have a single staff member that operates it. So if we were to have service gaps, if we don't have enough staff to provide consistent oversight, consistent enforcement, this bill also adds work to our plate. It would require that we report all of our inspection data every 5 years to the Department of Ecology. It adds extra steps in our permitting process, so it adds to our workload. We currently have one staff member, even though our workload already probably dictates to at least 2 FTEs. So we're operating at about half the rate of a lot of LHJs in terms of FTEs. So those service gaps could, in theory, give Ecology a reason to step in and take control over our program, which we don't necessarily want. So here, with this comment, just asking the board to consider ways to increase local funding. Tipping fees is something I want to bring up. So a lot of counties, a lot of local health jurisdictions, about half of my counterparts that operate under this same grant also have agreements with their local counties to receive a portion of tipping fees to fund their solid waste work on top of just the grant money that they're getting. So I'd love that to be considered. That additional funding just would help us to maintain local authority, not only ensure consistent enforcement, obviously protect public health, the things that we already try to do, but really to keep decision-making in our hands and not in the state's hands. So we hope that that there are still some changes as it goes through the House before it passes. But if not, then I think this is the time we really need to think about staffing up that program a little bit to solidify what we're doing.
And I want to support Erin's concerns. When I think about the value that we have here at the local level, and the quality of work that we do, we want to do quality work. We want to do a good job and retain that local control over our processes. And so when we look at this bill and knowing that the state could intervene, knowing that right now the ratio of inspectors to solid waste facilities is almost double what our peers is. This is in part why we wanted to start those conversations, especially when we saw the bill about tipping fees even last year, because while those tipping fees come from the counties, some of those costs can be passed through to the health district to support our staff in those inspection process, making sure we're compliant. And so I just want to underscore her sentiments, give it to our counties to think about, since it is a fee process, and we'd be happy to come talk with you guys more about that at your counties, about what that could look like. Yes, Karen.
Question. So Erin, what was the situation that precipitated this?
To the best of my knowledge, it's a situation that's been happening in Yakima County around some landfill enforcement up there, where the health district has, I want to caveat also that a lot of this bill, about 80% of what's in this bill will be supportive of our work, because it doesn't just allow Ecology to come in and take enforcement reins, but it also authorizes them to back us up when we request. So that's where Some of our state organizations have been trying to work with ecology to change the language to say, this would be great if it was at the request of the JHD, the local health jurisdiction. Because, you know, there's been some situations in Eastern Washington with some landfills, with some privately operated facilities that have come in from out of state, not operating with permits, kind of skirting around some things. And some local health jurisdictions right now are upwards of $1 million in legal fees with these facilities. These are big money facilities, which means big money for us to do enforcement. So having that backing of ecology when we request it is important. So there are portions of this bill that will help our work, but there are portions to say we need to really solidify how we're doing our work, because there's not a clear delineation right now of what does it mean. You know, how are they gonna interpret that we're not doing our job, or, you know, not forcing to their standards. So that's where some of our state partners are trying to get some clarification around that as it moves through. And I'm happy to follow up with any of you if you want to reach out to me about this one in particular. But just wanted to bring that through as that's kind of going through a committee right now. So yeah. Thank you.
Thank you. On that, senior staff comment, I've fielded a few calls on people wanting to know what the callback policies are on health district. So I don't know what the callback procedure is. I've never experienced any problems. Every time I've reached out, I've got an immediate answer. But I have had people call and want to know why their calls are not being returned. So if we have a callback policy, I would like to go into this. So, moving on to unfinished business. There's none. Somebody else has something they want to bring forward. New business, office health officer update, Dr. Stephen Krager, Heather Hill.
Hi, everyone. Give me 1 second. I'll get my slides up. Hope you're all doing well. Let's see. Okay. Let me know if you have any problems seeing, but it looks like it's working. Okay, a couple things I wanted to talk about today. Some things that have been in the news. So influenza, I'm going to touch on that since we've been talking about that the last couple months. I have good news in regards to influenza and measles. Measles has been in the news. So I wanted to cover kind of what measles is, give some context into what data looks like in regards to measles, both locally as well as kind of across the country and a little bit globally, and then talk about the measles vaccine. Okay, this is the only slide I have on influenza. We've talked about this before. These are emergency department visits for people with influenza. Red lines are Washington and blue are Benton and Franklin counties the last 2 years. So the dark lines this year, and we've seen a significant decline. We did talk about, you know, how rates were continuing to go up in February. That has peaked and has basically been going down most of this month. That is good news, and I know our hospitals are feeling a little bit less pressure from those influenza patients. Okay, let's talk about measles. So measles is an interesting one, right? We don't see it very much, which is great news. But it does flare up every once in a while. And if you've been in Washington the last few years, we did have, a larger outbreak in Washington State in 2019. But mostly measles cases are pretty sporadic, and that's true here as well as across the country. So measles is caused by the measles virus. It's a handy name in that way. Mostly spread through small airborne respiratory droplets when someone infected coughs or sneezes. It's extremely contagious. It's one of the most infectious diseases that we know of in terms of contagiousness. So this can change depending on context, but on average, one person who's infected can infect up to 12 to 18 people, as long as those people don't have immunity. So That's really not the case in most places now, right? Obviously, we do have pockets where immunization rates and previous measles infection is low, but most places we have pretty decent rates of immunization. So I've been a physician since 2017. I've never personally seen a case of measles. I've taken care of from the public health standpoint a few cases, but never actually seen a measles rash in person, I will say. But generally, it starts with kind of mild symptoms, cough, runny nose. You can have a pretty high fever that can make kids pretty sick, and red eyes. Those are kind of the classic symptoms we think of. And then we have that rash. I have a picture of it. It can look different, on different people's skin. It can present differently in kids and adults. But generally, it's a pretty I would say diffuse rash in that it kind of spreads throughout your body. Often starts on your head, face, and then works its way down. And that usually lasts 4 to 5 days. Let's see. So unfortunately, while a lot of people in the past were infected with measles and obviously survived, unfortunately, there is a large rate of complications. So about 20% of people are hospitalized if they don't have any previous immunity. That's often due to viral pneumonia, but there's other things that can cause complications as well. Death rate varies, but about 1 to 3 people die out of 1,000 who are infected. So not a huge high rate of death, but if we're talking about thousands and thousands of people infected, that can certainly add up, and I certainly wouldn't want to take that risk. It can lead to pretty severe ear infections. Brain inflammation is one, can cause some pretty severe long-term consequences as well as death. And obviously, when we're talking about higher risk people, anyone with immunocompromise, that includes pregnant women and young children, are kind of the highest risk for these complications. So just to put us in context a little bit, this is measles data about the last 15 years. You can see we had a large spike in 2019. That was partially Washington, but also there were just larger outbreaks across the country. I think what is making people just a little bit more concerned this year is that we've already had more cases in 2025, about less than 3 months into 2025, than we've had most of the last 15 years. So 2018 has been higher, and 2014, and obviously 2019. But we're kind of on track to have a really high, comparatively, rate of measles this year. This is across the country. The large current outbreak you probably have heard is Texas. It's also been associated with cases in New Mexico and Oklahoma. Texas, I just kind of wanted to point out what the cases are doing, and this is as of March 15th, and actually they've had more cases reported yesterday. So I think, well, I'll talk about it in a second, but I think what concerns me is that this isn't really slowing down. And I would hope eventually we would see kind of that rate slowing a little bit. But we'll see what happens. Again, locally in Washington, this is cases every year in the last 20 years or so. We kind of bounce around. And again, I've highlighted 2019 when we had that larger outbreak in Clark County. Last year we had 12. It really just varies. I will say the vast majority of these cases are associated with some sort of travel, and mostly international. So, and that kind of brings me to my next slide, which is we still globally have much lower rates compared to other parts of the world, which is great. I'd like to keep it that way. And while we're seeing spread in Texas, most of the cases of the last 20 years have been associated with global travel. I think, again, as I kind of mentioned earlier, cases with the Texas-associated outbreak are continuing to rise. And that's a little bit concerning that we haven't really seen that slow down. And then with all infectious diseases and public health, especially, what's reported is almost always an undercount. Not everyone goes and gets tested. These are only confirmed infections with a laboratory test. So we know there's probably more cases out there, but this is kind of the best number that we have. I'm going to talk about measles vaccine data in a second, but I do think this is a nice kind of real world example how the vaccine works. There's been 2 cases in people with 2 doses of vaccine out of the 279 cases reported. I know it. One thing I will note is that it says unvaccinated and unknown. It's often challenging to get people's vaccine records, right? But for the most part, states have some sort of information system tracking vaccines, and I interpret most of those unknown cases as being unvaccinated. I think that makes the most logical sense to me. All right, a couple more slides and then I'm done. So hopefully most of us have been vaccinated against with the MMR vaccine. So it includes measles, mumps, and rubella. It is considered, it's what's called a live attenuated virus. It's a very weakened version of the measles virus. That teaches our body to, respond to a real measles infection. It's very effective. It's one of the most effective vaccines we have. 97% after 2 doses. Kind of in easier terms, I like to think about, if 100 people are vaccinated, and then, over the course of their lifetime, they're exposed to measles maybe once or twice, 3 of those people might get infected. And that rate is much, much higher in people who are not vaccinated. We also have pretty good data on, those rare breakthrough cases that happen. They're just much less likely to have severe disease like hospitalization, that sort of thing. If you had a child recently, you probably know the schedule. We generally start at 12 months, and then somewhere between 4 to 6 years, we're trying to get kids before they get into kindergarten with that booster. And I will say, again, this is true of pretty much any infectious disease. Preventing it is always better than getting it. Again, just due to those complications that can occur when you get sick. I always love this graph. This is measles cases. Hopefully it's big enough for you all to see. From 1962 to 2023, we were talking about, a couple thousand, I think, in maybe 2019, or maybe 1,000 cases in 2019. We used to get, 400,000 or 500,000 cases across the country. The vaccine was licensed in 1963. We saw a significant drop in cases. We'd see little bumps every once in a while. We started to get data that immunity did start to wane a little bit, so that second dose was recommended. And then in 2000, we've been declared eliminated. That essentially means that measles in our country hasn't been shown to be transmitted for longer than 12 months since 2000, which is great news, but obviously something we need to keep an eye on. Okay, last slide. I just saw this today. King County had a measles case associated with travel in February last month, and then today, Snohomish County reported 1 case that was linked to the King County case, so likely exposed. So we'll obviously we're following that closely, and we'll kind of see what happens. Our clinic team has been planning and doing school vaccine clinics to help kids, stay up to date and catch up, put those times and dates. We had one a few days ago at Marcus Whitman, and I heard we had, I think, 60 kids. And again, this is a way we try to encourage vaccination, as well as just, provide a convenient option for busy families. That's my update, and happy to answer any questions.
Thank you, Dr. Greger. I do have a question. One is related to the vaccination rate in Washington State. Do we know what the vaccination rate in Washington State? The other thing is a comment on the immunity. As you know, it's possible to check IgG antibodies for measles to see what the immunity is, or it's waning or not. So some of those
Yes.
cases that are reported as unvaccinated, potentially even in the acute phase, they can still check the IgG and find out.
Yeah, those are great questions. Sorry, I'm gonna stop getting some Teams notifications, so I'm gonna stop sharing my screen. Okay. So vaccination rates in Washington. We I have the numbers somewhere, but not quite handy. Basically, we've hovered around kind of low 90s. It's ticked down the last couple years in Washington State, kind of to like 90% in terms of when we look at MMR specifically. So, let's see. Yeah, it really depends on the county that you look at as well as the source of data. Data is a little bit messy in regards to vaccination, but at least in Benton and Franklin County, as I looked at our school kind of immunization data, so the number of kids going into kindergarten that were up to date, and we actually do a little bit better than the state. Last year, let's see, Benton County was 93.5. We're up to date, and Franklin was 96.5. So our rates locally seem to be staying pretty stable. There again, I've seen a tick down kind of across the state of a few percentage points. Immunity. So you can check what's called titers, antibody titers. And I think for most people, if you've had measles in the past or you've had two vaccines, I don't think that's really necessary unless you have some sort of immunocompromise. But it can tell you if it can give you some idea whether you have immunity or not. It's not always perfect because there's other parts of the immune system that can go in. Was your question, Dr. Kwandi, like kind of checking a case to see if they, had IgG antibodies to see if they were vaccinated previously or not?
Yeah, I've been using it
Yeah.
quite a bit in my transplant population because a lot of them are concerned they're traveling
Yes.
and they're not sure. So
Yeah.
actually, my transplant population, I've been checking IgGs on them.
Yes, yeah, no, that makes sense. Yeah, someone who is undergoing a transplant is going to be severely immunocompromised, and so yeah, they often will need a booster, is my understanding. So yeah, that's an option.
Thank you.
So, Doctor, on those school vaccinations for the children, is this with parental consent or is this?
Yes.
After school hours.
After school hours. Okay, great. So they're informed and they have their parental consent.
Yes, absolutely.
Okay, good. Thank you.
Mm-hmm.
It's in coordination with school nurses, right?
So if you've had the measles before, you're immune to it now?
Yes, unless you've had, some sort of immunocompromise. There's the year I want to say is if you were born before 1957, I'll double check that. Essentially, yeah, thank you. It's essentially assumed that you had measles, just because of, again, how prevalent it was in the past and that you're immune. When we do a measles investigation, which I've done a couple times in my career, it's one of those things we try to figure out, right? Is someone immune or not? Because if they were exposed, we might ask them to quarantine. But if they're immune, like again, born before that date, or have evidence of protection in regards to antibodies or immunization, then generally we can let them kind of go about their business. But I will say it is difficult to trace sometimes, right? It's because it's so contagious anyway. But that's a tool that we use sometimes.
And with the measles, I'm visiting my doctor at this time. He's prescribing that I get the shingles vaccination because of the measles.
Yeah. So, gosh, I can't remember the age, but yeah, most people, I want to say over the age of 55, are recommended to get shingles. And
Yeah,
it's interesting.
It's over the age of 50 for the
Thank you.
shingles. And essentially it's 2 dosages. I'm not sure what the link with the measles would be, but definitely shingles something above the age of 50.
Yeah, shingles is associated with varicella, also known as chicken pox. So
Oh, it's
I've-
chicken pox, that's what.
yeah, yeah.
All right,
So yeah,
I
if
had
you've
it
had
wrong.
chicken pox in the past, then you are at risk for shingles. Yeah.
Did you have chicken pox?
No,
Lucky you.
I got measles twice.
All right. Thank you.
One of those was
Of
actually.
course.
Maybe one of those was actually a chicken pox.
I don't think so.
Alike.
My older brother never had them either until he got in the army.
Yeah.
That's bad when you're an adult to get chicken pox.
All right.
All right, thank you.
Thank you.
Resolution 25-01 says rule review, revision review and approval by Aaron Hockaday.
Right, and back again. Okay, hello everyone. Again, we've been talking about this for about a year now. So to kind of bring up to speed with where we're at the conclusion of our process for the on-site rule revision. Following last month's meeting, the FHD published our SEPA environmental assessment application. We did get one additional comment after that public comment. Amanda, did you print that out for them? So you should have, looks like this. So just wanted to bring that forward, is that the additional public comment that you hadn't seen last month. It's quite positive. It's from a land developer in Franklin County, just expressing their support for the proposed changes.
Well,
And
but I just texted him and I said, you do realize they increased the lot size, not reduced it. It was from 1 acre to 2 acres on Sandy Loam, right?
we reduced it from our previous rule revision.
Okay.
Yeah. So some of the increases that may be in there are state set. That's the state set code. So, as Jody mentioned, there was that increase that the
That was
state
just for
made.
one lot, for soil type of silt loam, very fine sandy loam,
Yep.
or clay. If they had a well on that lot, the lot size did increase.
2 acres from 1 acre.
And that
So
the
what was
state.
your reduction from to and from?
So our reduction was with the usable land area. And which was something new that the state put into their rule this year, where we asked for example, in that silt loam soil, we asked for 20,000 square feet of usable land area as a place where a drain field and its replacement could go. We reduced that to half, so now the requirement is 10,000.
The usable land area, and then also the vertical separation was a big one. That will open up a little bit more opportunity for development. So where we used to have 4 feet required of vertical separation, now we only require 3. So it allows developers to develop in areas where before they weren't necessarily able to.
And it also allows for more gravity flow systems to be installed over the alternative engineered design ones.
So following last month's Board of Health meeting, there were some questions about the homeowner install exams. We did send an email, came through Amanda, out to the Board of Health, just with some clarification around the exams. I think there were some questions about costs. We did clarify there wouldn't be an added cost for the exam. The questions would be very simple in nature and only focused on items that most frequently cause costly rework for homeowners and additional time for BFHD staff. So overall, we feel we've had support from industry that we feel the proposed changes in the rule have made significant efforts to bring us in line with the state codes in areas where we didn't necessarily need to have our own local provisions, consider industry needs, and remain protective of the environment at the same time.
So if you guys would like to have Jody go ahead and read the resolution into the record, and then you guys can decide how you want to move forward. Is that okay? Okay.
Whereas the Benton-Franklin Health District has the authority to regulate on-site sewage disposal systems for permitting of those engaged in installation of these disposal systems and establishing permits and fees and providing for an on-site waste management system. Whereas under the provisions of RCW 70.05.060, RCW 70.08, RCW 70.46.060, this board is charged with the duties of 1, enacting such rules and regulations as are necessary in order to preserve, promote, and improve the public health and provide the enforcement thereof. And 2, providing the control and prevention of any dangerous, contagious, or infectious disease within the jurisdiction of the health district. Whereas Washington State Board of Health has passed rules and regulations which are mandatory and binding on the boards of health. And whereas these rules and regulations require a substantial revision of the rules and regulations previously enacted by the District Board of Health of the Benton-Franklin Health District. Now therefore, be it resolved by the Benton-Franklin District Board of Health that rule number 2 be and hereby is amended, and that from the date of this resolution shall be read as follows on page 2 of this document.
Well, if it's state mandated, what decisions do we have in it?
With the lot size,
Any of
The state mandated language, we don't have any decision-making authority over. But we have local provisions in here that have been in place for many, many years, and those are the ones that we have that decision-making over. Those are all the areas Jody's been presenting on the last year or so have been all those local.
and each individual county that has their own ordinance is allowed to be stricter than the state.
Are
we
we
have-
stricter on any of them than the
Um,
state?
Yes, we are. For example, the state allows for septic systems to be placed on slopes up to 30% slope or 17 degrees. And we have 20% slope or 11 degrees. So we don't want our systems on as steep of a slope that the state will allow. We also asked for 12 inches of cover soil as a minimum over the top of the trench, whereas the state asks for 6. And a lot of things we came into compliance with the state. We went and met with their, so we are no longer as strict as they are. Where we are no longer stricter than they are, I'm sorry. We are a little stricter with the usable land area amount. The state went with the bare minimum, and we allowed for a bigger cushion because of the issues we have with nitrate contamination in our groundwater.
So what is the minimum lot size?
Minimum lot size, if the lot has a city or shared water supply, if there's not a well on that lot, the minimum lot size is 1/2 acre. And that part did not change, either by the state or by us. If the lot has a well or is the community water system, that lot must be 1 acre in size, except when it's a type 5 soil, which was the silt loam, very fine silt loam, very fine sand, or the clay soil. Those the state raised to 2 acres.
And again, I want to reemphasize too, that all of these, any local provisions that we've discussed or that Jody's discussed over the last year were the topic of that industry committee that ran throughout the spring and all throughout the summer. So we had representatives from industry, a representative from Board of Health, subject matter experts. We had on-site engineers who work in local industry to look through really carefully each of those areas where we do differ. Because we have conditions in our area, we have conditions in our geology, in our industry that just differ from the west side of the state. Whereas we feel sometimes with our state rules that they kind of center around what happens on the west side. And that's very different than our land and how we use and develop our land around here. So there was general consensus at the end of that process that all of the provisions that we have where we slightly differ were acceptable and everybody was in favor of them. And they are significantly less stringent than they have been in past years. So I think that's where a lot of the industry members were going, yeah, we're still a little different because we have to sort of, have rules that match our area and our side of the state. But we're a lot less strict than we have been in the past. So I think they were pretty favorable there in that regard.
So a question on cover of the drain field. You're saying the state says the minimum is 6 and we're going 12?
12.
6 inches is pretty
If,
shallow.
that's what I thought. That's why I would rather have 12.
Well, when you're looking for evaporation, it's not.
Okay.
That's what they're looking for on these drain fields, is evaporation. They don't want it to go down to the water profile. They want it to evaporate. So 6 inches makes more sense. And I don't think that we need to be any more stringent than the state's regs. Honestly, I don't. It's the way I'm gonna vote.
12 inches though is more protects there's a little more protection on the utilities, on the pipe and
So
utilities.
you got rocks around that pipe, so it shouldn't be able to be compressed.
But and then your guys' slope too, I agree with your slope difference because less slope's better than what the state's requiring.
It's dangerous for the equipment to be on that.
Correct. Yeah.
Yeah.
Wonderful. As for the 6 inches of cover soil, as you mentioned, it helps keep everything warmer. A lot of these drain fields are in people's backyards, which helps them be protected when people are digging in their yard. It gives a little cushion before you actually start digging up your drain field.
But also, like you're saying too, also temperature too, because I've had it before where there's actually been pipe frozen to where it messes things up to where if we do 12 inches, it's more protection, longevity wise.
That would be the deciding factor for me right there is it's freeze, but I don't think your water is gonna compile in those perforated pipe.
No,
Maybe the whole drain field will freeze. If it was
that's what I'm trying to get.
saturated.
Cause I've had it where even when I'm installing a water meter at 12 inches 2 years ago, I had an owner call me and had to come out because it was frozen. So that's what I'm saying. To me, the 12 inch makes sense temperature wise. If we lived in, Arizona, it'd be 6 inches, but 12 inches to where we live, I think that makes sense for longevity protection and stuff. But it's tough too, though, that we have to, they're mandating it to make, to make it work, but it still makes sense though, too, with the soil, the type of soil, because if we have type A, the septic system is smaller, type B, the septic system is bigger, this depending on what the soil type is, so it makes sense what they're explaining.
Well, I have yet to take Janae and another associate out to my mom's and show them the nitrate levels of the well that was drilled in the 50s, and the nitrates were so high you couldn't even make baby formula. And there was no farming or no septic systems in the area at that time. The nitrates aren't due to the farming or irrigation. It is due to the rock configuration of what we're dealing with here in the basin too.
And I think Marcy talked about that last time in terms of her experiences, and Marcy, correct me if I'm wrong, it was even in your work you're finding where disproportionately farmers get a bad rap for the nitrate problem.
Because of the nitrogen we put down on our crops.
We do have, and there's a lot of data going back in Franklin County as part of that WAMA and looking at kind of the peat moss and all of the other stuff that were part of that when things were, absorbing back then. But regardless of that, when you look at these rules, we don't want to compound any issues that aren't there, right? So when we're thinking about the bi-counties, just making sure that people are safe when they put in their septic system and it's not right next to their well. I mean, there's just some common sense things there that regardless of the nitrate issues historically.
I want to echo that too, because regardless of the source of the nitrates, if we have natural nitrates in our groundwater around here, effluent from a septic system is an additional source of nitrogen, right, from the ammonia in there. So some of the counties you see across the state that have slightly stricter rules, because we're not the only one, there's many counties that have their own on-site ordinance. The ones that do are typically your Puget Sound counties, because of the risk to the natural waters and your counties where there may be naturally occurring nitrates, or we're wanting to protect the ground from additional contaminants. And so it's not unusual to have some provisions in there that are really meant for protection of the groundwater and protection of the environment, to slightly increase some of that protection through the on-site provisions.
Any further questions? Hearing none, I will entertain the motion.
Mr. Chair, I'll move approval of the resolution.
Second.
And a second, any further discussion? All in favor signify resolution 2501. We do have a motion and a second. All in favor signify by saying aye.
Aye.
All opposed?
Nay.
Nay. Motion passes.
I didn't hear Dr. Kawan.
Yes, approve.
Moving on to childhood injury prevention update by Kelly Harnish.
Thank you for having me here today. My name is Kelly Harnish. I'm the Healthy Living Program Manager at Benton-Franklin Health District. And I wanted to just highlight a couple of our really great programs that we have to offer for both preventing childhood injury and violence, and also helping our youth in preventing and being resilient against the temptations of tobacco and cannabis as well. So next slide, please. Oh, we're almost there.
Yeah. I had to add sound, so.
Thank you. I'll have a short video for you on one of our slides. These are three of the staff members in my team who work specifically on childhood injury and violence prevention and youth cannabis tobacco prevention. Yehaida Lemus, Daphne Gallegos, and Sierra Kempney are all three working in this area. Yehaida works in the tobacco and cannabis prevention work, and then Daphne and Sierra both do childhood injury and violence prevention. I'll first focus on childhood injury and violence prevention. So we really follow the pillars of the Safe Kids Worldwide framework, and the pillars of Safe Kids Worldwide focus on protecting kids at home, protecting kids in cars and on the road, and protecting kids in sports and at play. And we're not talking about protecting them from, scrapes and bruises and things like that that are just kind of normal parts of childhood and exploring the world. We're really talking about, preventing serious injury and death. And so the ways that we do that is through, specifically this month being Traumatic Brain Injury Awareness Month, things like educating our community members about wearing helmets when bicycling. We work with our schools to establish safe routes to schools, and also work with our cities and our municipalities with that as well. And then we promote safe child passenger routes. So where, being in the proper car seat for the age and weight of the child. We focus on a lot of things outside of that, like water safety and even, safe storage of medications and safe firearm safety as well. Slide. One thing that's happening this week that we're really excited about is our annual Certified Child Passenger Safety Technician Training. We're hosting it, and we do so every year. This year, we're hosting it at the Richland Public Library, and we have 12 students enrolled right now in that program, and it'll culminate on Saturday with a car seat clinic. So community members can come to Catholic Hospital, and the newly trained technicians can check their car seats, and if eligible for a new car seat, they'll be able to get a car seat that's appropriate for their child and have it installed and learn how to install it properly.
Has that been pretty successful? I think it's pretty successful.
It is.
That's what I've heard.
Yes.
Okay.
My predecessor, so Annie Goodwin, ran the program for many decades, and it's been a really great highlight in our community. And so post-COVID, it was kind of, not really active. And so we've been doing by appointment here at Benton-Franklin Health District, and now we're launching the clinics again.
So if a child has outgrown a seat and the family's given another one, can that smaller seat be reused if the technicians approve it?
If it's approved. So if it's, known not to have been in a car accident, then it can be used or expired. So there's a date of when it was manufactured, and it'll say it's good for 10 years or something like that. And some of them have an expiration date printed on them as well. So we're excited to be relaunching this with our community partners. Cadluck has been very supportive, hosting it in their parking garage. So we'll be safe against the elements, both the heat and the cold and, rain and wind and so forth. So that's a big success for that program. Next slide. Another element of our child injury and violence prevention program is the child fatality review. And the child fatality review program is really an important program because we're looking at, cases of fatalities in children and looking for those protective and risk factors that were present leading up to the fatality, so we can identify areas in our community that we can help kids be safer. This program did happen pre-COVID, and we've brought it back starting last year. And we've had now 5 different meetings and focused on, I'll just look at the 2024 meetings. We had 1 meeting so far in 2025. But in our relaunch in 2024, we focused on firearm safety, household safety, poison prevention, and really that one was a joint review with our overdose fatality review team because the case is really related to fentanyl poisoning and vehicular safety. So these meetings are multidisciplinary. We don't do this by ourselves. We meet with partners and go over individual case reviews so we understand the circumstances that led to these fatalities. And then we really we identify recommendations that are at the systems or policy level to be able to mitigate future risks to children. And I'm really excited to share that just today we had a joint meeting between our child fatality review group and our Safe Kids Coalition to meet and discuss the 2024 recommendations and start to identify potential solutions and how can we strategize around those recommendations to bring them to fruition.
On your vehicular safety, because we've had a couple fatalities out in our area where parents jump in the car and they back over their child. Is that part of it?
I can say that in one instance, it wasn't in that review, but there was a case we reviewed where that did happen.
I'll go behind my vehicle and look every time I leave the door.
Right, it's haunting to think
I
about
have
those things.
grandchildren now, so I have children, I have grandchildren.
Yeah.
I know I look young.
Quickly.
Yes,
So Kelly, is any part of that vehicular safety looking at kids that might have gotten hit by a car? If they were on, there wasn't a sidewalk and
So
they were
traffic safety.
Yeah.
This particular review focused on youth who were passengers in a vehicle with other youth, and it just so happened we had 5 cases within a 1.5-year period that we needed to cover around that theme. And so that was kind of where we scoped it, but there's certainly, if we were to come across injuries that related to, a child on bike or something like that, being hit by a car, that was the case here. So this really had to do with youth drivers and youth passengers and kind of having to do with the safety of the driver's decision making and also the passenger having an autonomous voice and voicing if they didn't feel safe in that situation.
So is there a way to capture that data? Because I remember,
Absolutely.
I think a couple of years ago, a kid got hit on a bicycle and was killed in Richland. So
yeah, we do get all that certificate data, and so we create the themes based on and what we're seeing as being higher levels of something.
Thank you.
Awesome. Any other questions so far? So just to recap the recommendations, I won't go into them in detail, but with the firearm safety recommendations, we had 6 for both firearm safety and household safety. Poison prevention, we had 8 recommendations, and vehicular safety, we had 8 recommendations. And again, working with our partners to identify where we can lean on each other for resources and expertise to be able to address these issues is what we're heading towards and doing some strategic planning. Next slide. One thing we're also really excited to be now launching this month is our mouthful, Community-Based Violence Intervention and Prevention Initiative. And that's a grant through Commerce, the Department of Commerce in Washington State. We were awarded funding to start doing a landscape analysis. We are given training through Commerce. And then through that, we'll develop a specific for Benton-Franklin County's Community Violence Reduction Plan. So this is focused on youth violence reduction. And once we have a successful plan implemented, we have the option to apply for further funding up to $275,000. to then subcontract to do implementation of that strategy. So we're very excited. We're working with a lot of community partners. We've got a lot of buy-in from leaders in our community to participate in this program. And then lastly, I'll focus on the Youth Cannabis and Commercial Tobacco Prevention Program. We are the lead agency in our region for the Greater Columbia region to lead the cannabis and commercial tobacco prevention work. And I wanted to highlight a success from last week. We hosted our annual Southeast Regional Youth Summit. And there are other youth summits in the state. We hold ours in the spring, others hold them in the fall. This one was a great success. We had 250 youth attend this year, 19 schools, and we had 14 vendors come to the vendor fair. So this is like a conference for kids, middle and high school students. They get a lanyard and their own badge, and they go to different breakout sessions. There's keynote. They get to, go to the resource fair and pick up all the goodies that they're interested in. And we were really excited this year to get a great keynote from Big Bro Joe. I don't know if anybody has heard of Big Bro Joe Foundation. He came to do our keynote presentation and really focused on identifying your personal goals in 3, 5, 10 years and where you want to be, and understanding what distractions and obstacles can get in the way and how you need to stay focused on those goals. So it was really interactive. We also had a speaker for a breakout session for Work to Be Well. We had one of our other public health educators, Miranda, gave a presentation on the HOPE framework. So it was really well received by the youth, and I have a short video to share on the Youth Summit.
See if I can put this to work. I've never done it on the sound before.
And thank you to Amanda for putting this video together on such short notice. She had like a day and a half.
Hey, what's going on? I'm here, y'all, at the 2025 Benton-Franklin Health District Southeast Regional Youth Summit. I'm your keynote speaker today, and we're gonna tear it up today.
I think it opened up on YouTube. Oh, well, it's because I shared the window rather than my screen. That's why. Okay, one moment. Okay. There we go. Take 2.
Hey, what's going on? I'm here, y'all, at the 2025 Benton-Franklin Health District Southeast Regional Youth Summit. I'm your keynote speaker today, and we're gonna tear it up today. So stay tuned. We got more to come.
Does anybody have any questions?
I just want to say real quick that, I think that's a great program for our youth. It kind of shows them kind of look at short term, a little bit midterm, and maybe a little longer term in values and education. So I think it's actually a pretty cool thing. And I'm glad that you guys are the lead agency on it. Good job.
Thank you. Thanks. And it was just such a good visual where you might have noticed the ball being tossed back and forth. The kids in the center were representing the distractions and things that can get in the way of our goals, things like self-doubt or drug use or some of our early childhood experiences that are less than positive. And so those distractions and barriers can get in the way of our goals. And the more kids he stacked in the middle, the harder it was for the two kids to catch and throw the ball to each other. But he's a former pro football player. And so his whole mindset is keep your eye on the ball, always catch your ball, always follow the ball. And so he really, did a great job expressing that to the kids. And he was a little celebrity afterwards. He was getting lots of requests for signatures. So really pretty cool to get him out there and see how the kids enjoyed that. Thank you.
All right, thank you. Moving on to branding community survey results on that.
Hey, try to keep it short as always, I hope. Okay, so a few months ago, we brought to you the idea of possibly changing our name. That was something that, was addressed. And so we wanted to just follow through with it just to see, hey, what was the research? What did we learn from our community? So this branding technique was through Zen City. We offered first a survey to our whole community. And it's important to note that Zen City had 709 community members responded from December to January. They used data from the Census Bureau, and the whole goal was to make sure that they matched the distribution of race, ethnicity, age, and gender to ensure a sample representative of our entire population in both counties. So that is good news there. And then also conducted internally staff and also senior management, as well as managers and supervisors, tons of surveys and conversations. So I feel like we got a pretty good scope of what we're looking at. So next slide, please. Okay, so here we go for the community response. We asked a lot of different questions, but I'm only highlighting kind of the things that I thought were unique. We asked the community their thoughts on if we should change our name to Benton-Franklin Public Health. 39% said that there were no concerns, but there were a lot of people that were just kind of ambiguous, and there was a lot of ambiguity in regards to some people didn't care. Others, only 6% says lacks governmental authority. So one of the big issues that our staff had was we were hoping that, or thinking through, that if we changed our name to Benton-Franklin Public Health, it'd be less governmental, more local, more inviting, more comforting. But we found that this wasn't really necessarily something that the community really cared about, or it was a big concern to them. So a lot of people said from our community, too generic and lack of alignment with services was their concern. So if you go to the next slide, we did ask how they felt about Benton-Franklin Health District. Again, we're out of COVID. We're trying to find different ways to connect more locally. Again, it's kind of staying away from the governmental vibe because we want everyone to feel very comfortable. And we found that 73% of community members believe that our current name pretty much reflects our services. So I was really excited to see that. You can see that there's 5% said not at all, 7% says don't know. We had pretty even amounts of some extent. Oh, I copy and pasted that twice. I apologize. So anyways, on that note, we did have roughly a little bit more on some extent, and then the overall 41%, I apologize, was for mainly all felt like it was the most current name.
Well, if you looked at the previous slide, you had the numbers of it.
Yeah, there's there.
You're
I
good.
swear. There's another one. When I moved it from Canva to PowerPoint, you'll see on our next slide, the neutral, the L went into escaping. So I looked at that on the slide and said, that's cool, great. I swear I'm better at communications than my slideshow. So the staff conclusion, okay, so when I first ran all staff data, we got like 29 major contributors to it. And then we ran it a few more times with management and supervisors. And really the biggest concern was bandwidth. We are just strapped tight. We're a skeleton crew, which is not a bad thing in a lot of different ways because we've got a lot of capable staff members. But when looking at this, 52% saying no, I think that's pretty clear. When you've got 17% neutral, that does, kind of, But when you're looking at it, we own who we are, and I'm deep down a traditionalist. So I think it's really valuable that, we're moving forward with the conclusion of not changing our name. So that is, unless y'all have other options, I think that's the staff have spoken. And that's kind of how we're gonna move forward on this. And again, this is all paid for. This was 2024's goal, but we did the research a little bit more to make sure we were doing this right. Because this isn't something we want for the next 5 years. We want this to be longstanding. So if you go to the next slide, what was fun about this survey was that people like us. It's a great feeling. Overall opinion of Benton-Franklin Health District, we got 64%. 25% were neutral and 10% were negative. Actually, men were more negative for us than females. I don't know if that's just because a lot of people are involved with WIC. Our main goal in the communications department has been highly involved in making these programs. As you saw what Kelly was doing, even with septic and WIC and all of these other programs that we do, we're more than just vaccine clinics. We're much, much bigger. And so that is our goal, is to try to be that resource for our locals and our community members, and to really learn and listen to them on what they need. So that was fun, 64%. Next slide. Zen City did a great job of breaking down some of the top words that really came forward in some of that data. We were glad to hear that we're caring, we help people, there's health, there's public safety. It was a really positive feedback here. We've got 2 small, very small ones that were sanitary and COVID. And then the bigger ones surrounding that are heart, community, government. There is like power and immunizations. There's that governmental feel as well, but we're effective. I guess we're clean, so that's good. We have inspectors, integrity, and I think overall just the fact that our community seemed to find those caring, help, healthy, and public safety as their key valuable words. It makes me feel like we're doing the right things in the communications department. And again, it's highlighting our staff that we're so much more than just one thing. So our last slide is a quick conclusion. As I said earlier, we have no plans to change our name. We have learned that, again, 64% of people really like us. Some are like, I don't really care. Smaller percent that don't. We need better communication with our older populations and the Hispanic community. We did find some good feedback from them. To give you some specifics, 18 to 34-year-olds, we had 51% have seen our communications more. When you look at 35 to 54, it's about 35%. And when you look at 55 and older, it's around 37. So we're not reaching these certain age groups, but I think that we could do more. What brings this to kind of an interesting point is finding different ways to reach our community. We learned through Lineage Logistics Fire that, social media wasn't how everyone got their data. So I'm working collectively with PIOs, with law enforcement, sheriff's office, fire, and also our cities and counties to find better resources on how to communicate with those populations. Facebook was also the most used social media platform. I can say that we have more people that respond on Facebook than we do Instagram. 90% found that BFHD communications that they saw or heard found them at least slightly useful. So that's good. I should have showed this slide with the pie because it says useful, slightly useful, I don't know, not as useful, and not at all. So on the bigger percentage, that was actually pretty good. So to give you some context, I'm just making sure the data and how we say it is accurately stated. So yeah, 90%, listen, that's great. Most people saw the logo on clinics, offices, and other physical locations. Huge shout out to our partners. As most of you know, 15 weeks, I went to my OBGYN, and we had a sign there for our postpartum and parenting support group, and right there in the office. So it was really cool to see that. I didn't even know the team was doing that. And so when I saw that, I was thinking, wow, this is really an opportunity for us, again, to show what we can do with the community and how we can help and serve. So those are my conclusions. Again, if you want more distinguished fine point data with better spelling, I'm happy to send that to you. But in terms of keeping our name traditional, Benton-Franklin Health District, anyone questions? Yes.
Yeah, on your circles there with the numbers, is that all supposed to add up to 100?
Yeah, no, that's the one where I screwed up.
Well, that one there adds up.
Yeah,
82.
that doesn't, yeah.
That's over 100. The other one's under 100.
Yeah.
I was just curious.
There was a flip flop on that one. I'll apologize for.
That was 98.
But
Amanda doesn't work in our data department.
I'm a numbers guy, so I'm just saying, I add up numbers when I see them.
Don't worry, I'll send you an email. You'll get one from me, like exact data. That was fun. Sorry about that.
I'm just teasing.
At least you were listening, so that's good. That's good. I've got people.
Wasn't it gotcha, Amanda?
Yeah, it's a test, so just want to make sure that everyone was good with it. Any questions, any concerns other than the numbers?
Say that 93% of all statistics. So.
Oh, well.
No, but
This was from Zen City, so they did a good job for us. So awesome. Great, thank you. Thank you.
moving on to PHAB accreditation private product.
Really quick, everybody, I know we're over time, so quick announcement. Carla Prox, Senior Manager of Community Health, we've been trying to keep you updated on our Public Health Accreditation Board status and process as we moved along. The Public Health Accreditation Board nationally announced that Benton-Franklin Health District successfully achieved reaccreditation the first week of March of this year. Yay. So I just want to let you know, we made it, we're good for 5 more years. We're one of only 400 local health jurisdictions in the nation who've been able to successfully make it through the accreditation process, and one of 3 in the state. So Kitsap, I'll give a shout out to Kitsap, Tacoma Pierce, and Benton-Franklin. So people we think that are really great colleagues around the state, and we are in alignment with them in our ability to do our work. So we're very proud of all of our team here, thankful for your support and our staff for getting us through this process, and very grateful. We don't have to start really thinking about it too hard for another couple of years, but again, it gives us great guidance and guidelines and standards and measures that we all implement in our daily work so that next time it won't be so tough, right? I will give a shout out. Department of Health is also an accredited health district or health department in the state, but only three locals total. So we're really more proud of our team here. Thank you.
Thank you.
I just want to add one thing for you guys. Carla was absolutely instrumental in helping us push this forward. Our reaccreditation actually came in the middle of the pandemic. We were able to do an extension, but when you look at that, keeping up on your policies, keeping up on our processes, she, this is my opinion, has helped us achieve reaccreditation. Lots of other key stakeholders in that, but my hat's off to her in helping us do this. So thank you.
Yes, thank you. Moving on, approval of vouchers. I will entertain a motion.
Go ahead. We'll have a guy with the glasses, just put them on, go ahead. You look distinguished.
Making motions. Go ahead.
I can't, I don't have my glasses.
I'll make a motion.
I can read.
Vouchers 11-2 2025 through 21-25 in the amount of $1,123,246.72.
We have a motion. Do we have a second?
Second.
Any discussion? Hearing none, all in favor, signify by saying aye.
Aye.
Any opposed? Motion passes. The date of the next meeting will be April 16th, 2025. This time I will adjourn the meeting. Thank you, everyone.
Thank you.